So, as a prelude, I'd like to take us back to the World Cup of 2006, which you'll recall took place in Germany. And the World Cup finals between France and Italy, and I'm sure we'll all remember this fantastic event. So this is Zidane headbutting Materazzi in a fit of pique. And this is the way the Germans in the audience saw this. However, the French saw things a different way. This is how the Italians saw things. And this is the Americans' view. And the press reported it this way. So how you look at things depends on your perspective. And for the next 50 minutes or so, I'd like to tell you about my journey and really my perspective of our academic health science centre and how within our cardiology unit we've evolved really in the context of the tripartite mission of clinical cardiology, teaching and training, and academic cardiology, and I'll let you all decide which of those applies best to you. Those are my disclosures. Okay, so there's a moment when I finished my training in Dundee, which was a fantastic university. I had a really great time as an undergraduate. We had a really important decision to make. New South Wales had just changed their course from a 5 to 6 year course, and they were desperate for young doctors. So all my mates signed up to go to Sydney for the year. So I needed to decide whether to do the sad medical rotation in Dundee, or go and join my mates in Sydney and have a fantastic time. And obviously I was completely mad because I stayed in Dundee. But there were some really important things I took out of that period. So this is Ninewells Hospital, which is on the banks of the Tay. You can see it's a really big hospital because unlike North West London, they've managed to close all their small hospitals down, merge them into one unit, and they've got their big clinical practice and their clinical academic units all together in one big department. This is part of the new hospital. Believe it or not, in the 80s and 90s, this looked bright and shiny new, but obviously it hasn't quite worn with time as well as it might have done. And these were some high-rise flats here that look right over on the car park. So whenever you nip into the hospital, people run down and break into your car, nick your stereo and disappear again. I'm sure that hasn't changed. But some of the important things I take back from Dundee. First of all, the key people who influenced me the most were not my consultant, the consultants I worked for, but the junior doctors, the registrars who were there. And unfortunately, these are contemporary pictures rather than pictures from 20 years ago. This is Chim Lang and John Jankowski. Chim was a clinical pharmacology registrar who just finished doing his research on ACE inhibitors and heart failure. And when I was sitting in the coffee room with Chim would always used to talk about studies, and you know, the conversation was always about research. And Chim kind of supervised me writing a couple of review articles while I was an SHO. And John was an amazingly vibrant, hard-working, fast-living gastroenterologist. So he was doing his clinical gastroenterology training and at the same time doing his MD in his spare time. And he got a lot of the house officers and SHOs to do a bit of work for him. And so I got engaged in his research. And essentially, I got involved in a kind of clinical academic culture when I was there. The other important thing about Dundee that I took with me is this Alan Struthers, who was the consultant clinical pharmacologist, had the most to do with in my junior training. The Clin Pharm department would pick the best students who qualified in their final years, and they'd organise them to do research in their departments in 3 years' time. So people would do their house jobs, do their SHO jobs, and then work seamlessly into the research departments. They'd handpick the best people. I wasn't one of those, so I ended up having to move out to progress. And so I applied for jobs after I got my membership. And I met these 4 people who interviewed me for a research job looking at cardiovascular structure and function in hypertension. Jim and Simon were registrars then and looked after me fantastically. And Rodney and Peter ran their respective units, and I'll talk more about these people later on. But whenever I look at this slide, it brings a smile to my face, because Mary's was a fantastic time then. We all worked hard, but after work, everyone would go down to the Phlegm. So it was a fantastic social life. And I came down from Dundee thinking, Mary's would be dead posh, no one's going to talk to me. And it couldn't be further from the truth. Everyone called each other by first names. It was a vibrant department. Essentially, this is a jobbing cardiology department, high volume jobbing department, but this interaction with the academic unit led to a really productive period for me. And we had fantastic fun. I joined the football club, so even though I was about 25, I had another kind of 10 years of medical students playing for Mary's and then Imperial, and this really it brings really fond memories. But again, it reinforced my kind of mindset of clinical hard work and doing research together. So I did my training in North West London, and then in 2000 was appointed as a cardiologist at Mary's. Rodney made a job for me, basically. And Julian Natel, who was the chief executive at the time, after my appointment congratulated me and said, "You're really lucky. You've come at a fantastic moment. This is the Paddington Basin. Brompton Harefield, we're going to move to the Mary's site. This is the Brompton Harefield building next to the Queen Elizabeth Queen Mother building. This is the old Mary's going to decant over here to a brand new build, and here is an extension of the medical school. This is going to be a single West London site, kind of a hub of cardiovascular academic and clinical practice that will compete with the Mayo and Cleveland Clinic." That was the vision in 2000. And at the same time, the government put lots of money into the NHS, and it started out with coronary heart disease. So they developed the National Service Framework, set very high standards for certainly cardiology at that time, for the expectations of commissioners and providers, and so there was a lot of money coming into cardiology. So it was a fantastic time, and this turned out to, this dragged us up to European levels of cardiology practice from kind of third world levels, but unfortunately this all imploded, and we're maybe a little bit further forward, but not that much further forward in terms of getting our single West London unit. So what did I do when I first started? Well, my senior colleagues, Rodney Fowle and Wyn Davis, had set up fantastic high-end services. Rodney had developed angioplasty. We were one of the highest volume centres in the UK at Mary's at that time. Wyn Davis had set up EP, electrophysiology, from scratch, and Mary's was a world-leading, world-famous centre in electrophysiology. But I saw it as my role to kind of develop the infrastructure. And so I developed the echo service, developed heart failure, chest pain, and set up databases to try to kind of correlate patients and coordinate them. So I think any service, any research program needs a solid clinical infrastructure. Building on my kind of senior colleagues, Rodney, Wyn, Nick, who'd set out and set up a really good, fun training environment for juniors. I hope I continue to contribute to that and support that. And then importantly, I got involved with Richard Sutton, who ran the cardiology training program for North West London. And I'll talk about my experience and commitment to that as we go through. The other thing I was really determined was, although I was and am a full-time clinical cardiologist, I was determined to have an academic interest during my career, and so that was an important aspect as I kind of took on my new role. So just as I was appointed, these were the kind of research streams we had in train. And I'll take you first here to tissue Doppler echo. This was developed in Edinburgh in the early 1990s when clinicians and academics realised that actually you could get great value from focusing your Doppler not just on the blood pool but also on tissue, and look at tissue motion. And particularly at the long axis, because the apex is relatively fixed. So any kind of motion, shortening and lengthening, is actually active contraction and relaxation of the heart rather than the heart moving within the body. And although we weren't an innovator in this area, I think we were an early recogniser of the value of this, and so we incorporated this methodology in a lot of our large studies. So we collected serial data at a very early stage, and Bal Wasson started out developing this methodology in our department, and Andrew Sharp followed him. Becky Lane was the research fellow who started out an interest in biventricular pacing. I'll come to that later. But in retrospect, most importantly, was the work we did in wave intensity analysis. Now, this was invented by Kim Parker. Now, Kim, there are no pictures of you on the web anywhere to be found, but I thought this was an apt picture to represent you. So Kim invented wave intensity analysis, and Alan Hughes, who knows everything about everything, and is a fantastic translational academic, really brought this technique from the lab to the clinical area. And Kim had developed this invasively with colleagues at the Brompton originally, and Alan really developed this and brought this non-invasively, and I'll talk more about that later. But Steph was our first research fellow in wave intensity analysis, and she'd bring some data to Alan, having been analysed, and then a few weeks later Alan would send it back to reanalyse it with a slight tweaking of methodology. So she had to go through and analyse the same data multiple times till we got it right. But this has turned out to be a really, really important part of the work in our department. In parallel, my senior colleagues, Peter Sever and Neil Poulter, set up the Ascot Study, which basically in the UK and Scandinavia set out to test the new antihypertensive agents versus some of the older agents, and also whether there was added value from a statin or not. And this was a double-blind placebo-controlled trial. And the importance of this for our unit was that it enabled us to do sub-studies, and led by Simon Tom, Alan Simon and I, with our colleagues in Dublin, designed a study whereby we'd intensively phenotype the heart and arterial system, and would serially assess these patients with echocardiography and carotid scanning over 2 time periods during the study. So it's a large cohort of 1,000 patients we've got mortality data on, and who have been really extensively looked at. So it really was a fantastic opportunity for us. So before I move on from that, I just want to give you a flavour of some of the things that come out of that. So we've got nice cross-sectional data, because in Mary's we've got a very ethnically rich population. We have the opportunity to look at ethnic variation in disease, and because we inbuilt tissue Doppler into our population, we've got very robust methodology to look at diastolic function in these populations. And very interestingly, you can see that in our Afro-Caribbean patients, diastolic function, even when matched for all other factors, was significantly lower than white Europeans. And if you look at the known aging effect on diastolic function, this is each decade, you can see the decline in diastolic function. You can compare that to the effects of ethnicity. So if you've got hypertension, you're Afro-Caribbean, that's the equivalent of 18 years of extra age on your diastolic function, and that's probably important when you consider that the rate of heart failure in our Afro-Caribbean population with hypertension is much, much higher than white Europeans. If you look at some of the serial data we've got, looking forward, these measurements of long axis function are very important for predicting prognosis. So these are pretty well patients. These are hypertensive patients with 3 other risk factors, 2 of which can be male sex and age over 50. So you don't need to work too hard to get into these studies. And these patients who are asymptomatic, if you've got significant diastolic impairment, you've got much greater mortality over the next 5 years than if you haven't. And this is much stronger prediction than left ventricular hypertrophy or other known factors. And again, these are kind of novel findings coming out of that work. Because we measured data on more than one point, we can look at serial changes. And with both agents, there was a decline in left ventricular hypertrophy after 1 year, and a further decline after 3 years of treatment. So left ventricular structure improved, but diastolic function deteriorated over that period with both agents. So there's a dissociation of structural improvement but functional deterioration that's important and tells us something about the treatments that we give. Okay, I want to move back to wave intensity because this is really the area that has been probably most important for our unit to date. So essentially, wave intensity seeks to derive the energy waves from pressure and flow data that actually cause changes in pressure and cause changes in flow. So you're going backwards And the reason that's useful is it can tell us about the events that cause the changes in pressure and flow. This is invented by Kim, or Batman. And basically, if you think about a branching vessel, if the heart's at this end and the heart contracts, when it does contract, there's energy that's imparted forward that increases pressure and increases flow. And every time this energy wave hits the bifurcation, most of the energy goes forward, but a small amount of that energy is reflected backwards. And the reflected energy, it increases pressure in this vessel, but because it's in the other direction, it reduces flow. And hopefully an illustration here makes it easier to get your head around. So basically, here's pressure and here's flow in the aorta, and these are the events that drive pressure and flow changes. So with wave intensity, if the wave comes proximally, it's presented above the line. If it comes distally, it's presented below the line. If it accelerates flow, it's in black. If it decelerates flow, it's clear. So basically, this wave that comes proximally and accelerates flow is due to cardiac contraction. That's probably easy to get your head around. What happens after the heart contracts is at every bifurcation there's a reflected wave that comes back. And this is a summation of all those waves. So this reflected wave is coming distally because it's come from the distal circulation. And because it's coming backwards, it decelerates flow. And if you go and look at pressure and flow here, you can see what happens. When you get the reflected wave, there's an inflection upwards because this reflected wave increases pressure. But look what happens to flow. It decelerates flow and so attenuates flow. In early diastole, when the left ventricle relaxes, this causes a decompression or suction wave. So you can see that reflected in the pressure and flow velocity tracings here. So this is work taken invasively in the aorta. And some of our early research looked at taking this to the echo lab effectively. And we used Doppler to assess flow, we used tonometry to assess pressure, though you can use wall tracking. And basically this is the pattern that we get in the carotid artery after much work by Alan and Kim. So again, you can see the forward wave from cardiac contraction, and this is interrogating the carotid. So there's a reflected wave from the head coming backwards. So here's the reflected wave. We think this is a re-reflection of this wave, not quite sure. This is another reflected wave. It's coming from the body. It looks a bit strange because why should a reflected wave be going, looking like it's coming proximally? And the reason for that is we're interrogating from the carotid. So the wave comes back from the body. It would be going backwards towards the heart, but it goes back upwards into the carotid. And this is LV relaxation again. So the early part of our work was really developing the technology, assessing patients with hypertension, assessing patients with heart failure. I want to go slightly to one side now and just talk about teaching and training. Because another important aspect of the work, something that I've done and my colleague Dara Francis has done subsequently, is in getting involved in the North West London teaching and training programme. Now you'll recall in the late 1990s, medical training was significantly changed from a previously unstructured system. Things were now centralised and structured, and Richard Sutton was appointed as training programme director. And I can't emphasise how important Richard has been to most of us that have qualified and trained in North West London over the years. Richard always looked to support the juniors, and also because he is academically minded, which is very important, he always looked to support people who wanted to do research, and even if there were reasons within the system that they shouldn't do it or that there were bars, he'd make it happen at somewhere or somehow. So Richard was very important, and certainly as a young consultant, I enthusiastically joined the committee, and sneakily, when I was assessing people during the ARCPs and other things, I'd identify the really bright trainees and invite them to come around to the unit and come to meet us and see what we're doing. So it's a good way of getting good people into your unit. Okay. Now, then Darryl Francis came. So Darryl is an amazing person. He was a game changer for our department. And he arrived to us as a senior trainee who had just rotated to come to St Mary's. And bizarrely, Daryl was planning to apply for clinical consultant posts. And I often say to people that I think my single most important contribution to cardiology was helping to persuade Daryl to become an academic rather than a clinical cardiologist. And you know, clearly he's a born academic and will change the world, is changing the world and will change the world. But I think an important aspect of this was the environment that we had, a friendly, supportive environment driven by my senior colleagues. And I think the tone of leadership in the department set by Rodney in cardiology and Peter Sever in the Clin Pharm department, and the interaction at ICCH that we had was a really, really important reason that Daryl decided to stay and make his career rather than become a jobbing cardiologist in a DGH. So Daryl was a game changer to us, and about this time, we're in our next wave of clinical research fellows. So here's Zach, Justin, Charlotte. Beth was a physiologist then. She's subsequently done a PhD in our department. And this is I think this is the England training camp prior to the 2006 World Cup. And the press all thought that this was the golden generation of English footballers. Clearly it wasn't, but they almost got it right, because actually it's a golden generation of research fellows and young cardiology clinical academics, which hopefully you'll see later as we go through. So I just want to give you a couple of illustrations of why Daryl really changed the parameters of the department and put us up to a completely different level. So before Daryl arrived, we're interested in biventricular pacing for heart failure, and Becky was the research fellow driving this, and Wyn Davis and Nick Peters were the electrophysiologists who were supervising Becky. And for those of you that don't know, biventricular pacing aims to resynchronize the heart in patients with a broad QRS and dysynchrony. And perhaps you can see that this left ventricle here, the septum and the basal lateral wall don't really contract together. The apex is akinetic and dead, and after resync pacing, you can't do anything about the dead muscle, but perhaps you can see that the septum and the lateral wall are contracting together, and you can understand why cardiac output might be increased. But importantly, what this technique does is it improves patient symptoms and improves life expectancy. So it's a really important technique. And Becky did some painstaking research using tissue Doppler to look at timings of wall contraction as we alter different settings of the pacing machine. We alter lead position and really got a huge amount of data and put some good work together. However, then Daryl comes along, and Daryl says, I don't think we should be doing this. The whole world can do this. There are other centres that have got far higher volumes of patients than us. We should focus on things that are difficult to do. We're bright, we're determined. You can't compete with the Mayo Clinic and the Cleveland Clinic. Let's focus on areas that we can't do. So in a nice way, Daryl hijacked the whole research programme. Decided that we wouldn't use echo, because echo is not very good. And he thought of using finger plethysmography to look at blood pressure and look at blood pressure changes. And it's not very accurate in measuring blood pressure, but it is very reproducible. And it's only changes that we're interested in, not absolute blood pressure. So what Daryl thought we should do is to change the settings and look at the changes in blood pressure. Unfortunately, after a couple of seconds, what happens is the vascular system either vasodilates or vasoconstricts to adjust the pressure, and so the changes get attenuated very quickly. But again, what Daryl decided to do was then to just alter the settings very quickly, going from one setting to the next, and then signal average these. And if you do that, you can get very nice tracings in blood pressure changes as you change your settings. And you can see here, the best blood pressure is at this setting here, and if you change the settings, the blood pressure reduces. So in other words, this is a very reproducible way of getting the setting the best way possible with biventricular pacing. And Zach, who's just been appointed to the staff, was a research fellow who drove this work forward. You can see here the reproducibility of this technique is much better than echo methodologies. And Zach looked at this for different AV delays. He looked at it for different heart rates. So in other words, you could argue there's no point in doing it at a heart rate of 70 a minute, because when you're exercising, your heart rate, if you've got heart failure, is 120 a minute. And so he looked at optimization at high heart rates, and then he exercised people on the treadmill and showed that actually if you do high heart rate optimization at rest, you get equivalent setting, best setting as you do with exercise. So it's a very, very nice program. And this is just a way of expressing the best setting. As you move from the optimal AV delay, your blood pressure reduces. And this is looking at VV delay, so the difference between the left and the right ventricle in terms of pacing and AV delay. And again, if you do multiple measurements, you can get the best delay that optimizes AV and VV delay. So from something that's a concept, Daryl and Zach have taken this through a series of experiments that we believe is a technique that really make a big difference to patients. If you can get an extra 20 or 30% from your biventricular pacing by getting the system properly optimized, then actually for almost no cost, you get an extra benefit. And so that's very important for our healthcare system. And the BHF and our BSc have funded a randomized controlled trial now, looking at no setting, so factory setting that most people do, versus echo optimization versus Finepress blood pressure optimization. So that study is ongoing at the moment. So we think and expect this methodology will be better. If it is, it's easy to automate. You don't need a skilled person to do echoes. You put your finger in the machine, and after a period of time, it comes with the optimal setting. So it's widely applicable. So we'd hope, we'll find out when the randomized control gets published, that we can change practice. And this is something from concept taken through to affecting real patient care. Just another area where, just an example of how Daryl has really taken us to a different level. This is the work we did before Daryl arrived. Basically, we were interested, as I mentioned, in tissue Doppler. And we looked at tissue Doppler imaging, assessing right ventricular function before and after cardiac surgery. And it's well known that immediately after cardiac surgery, the right ventricle takes a hit and doesn't work as well. And so you see a decline in right ventricular function immediately after surgery. But we showed that this decline extends out to 18 months and beyond. And that occurs whether you operate on pump or off pump. So it's not a factor of putting patients on bypass. So it's a very nice observational study, and certainly going out to this duration was a novel observation. But of course, Daryl, with his discipline, made sure that in our subsequent studies, we did things properly. We assessed people not just before and after surgery. We did interoperative theory. This is Beth, who's our PhD student who did this work. And also, Daryl devised with colleagues in Calgary a little pressure manometer that you put in the pericardium to measure pericardial pressure as we did the technique, because we kind of suspected it was the pericardium that was the issue. There are a number of theories as to what might be the reason. Was it the heart being open, the light and heat damaging the heart when it's open? Was it grafting or not grafting the right coronary artery? Could it be the pericardium? And you can see very neatly, kind of with real-time measurements, it's precisely when the pericardium is opened that the right ventricular pressure drops, velocities drop, and this is on pump, so you can't get any data, but after pump it stays down. And then if you look at operations that minimally affect the pericardium, so this is robotic bypass grafting, minimal AVR that one of our surgeons, Roberta Casula, specializes in, and this is, I think, lung surgery, so we don't open up the pericardium. You can see in these areas where the pericardium is not disrupted, there's no loss of pericardial support, the RV velocities staying nice and high. So very elegant work, and again, it's just an example of how kind of Daryl's kind of improved our unit as a whole. So I just want to go back to Ascot. So in the mid-2005, the Ascot results came out, and fantastically they showed that amlodipine and perindopril combinations, the neuroagents, improved prognosis in patients, fewer cardiac events and procedures by a significant amount, despite similar blood pressure control. A lot of this was driven by stroke, so a very, very big stroke reduction in patients treated with these neuroagents. So the question is, why is there a difference? The blood pressure control is the same. Why are these neuroagents, why do they seem to be more effective? Well, over the previous decade, there's been a lot of interest in the blood pressure tracing in the arterial system. And in particular, this inflection point here. Because as I've mentioned, what largely contributes to the blood pressure tracing is a forward wave contributed by cardiac contractions. This is the pressure imparted by the heart, but then a reflected wave, and this is the pressure imparted by the reflected wave. And when you add this and this, you get the overall pressure. And you can calculate, or you can calculate what's called the augmentation index by looking at the distance from the inflection to the peak pressure, and express that as a ratio over the pulse pressure as a whole. And some people, led primarily by a Rorke's group in Australia, have created a little algorithm that from this blood pressure trace, based on this inflection point, it gives you an idea of what the incident pressure is, i.e. the pressure that comes from the heart itself. And that led to the Cath study, which essentially tried to differentiate from the tracing that you get what the central aortic blood pressure was. And you can see between the two agents, the brachial blood pressure was much the same, but when you apply a transformation to estimate the central aortic pressure, this was significantly lower in the amlodipine and printable arm. And the study was, some of the senior investigators in the study are people from our group who you'll recognise. And this was, I think, the highest cited paper in circulation in 2006, so it attracts a lot of interest around the world. Now, the trouble with augmentation index and looking at the tracing is it's fine if you've got a clear-cut inflection point, but in many patients, particularly older patients, it's actually very difficult to know where the inflection point is. So you can't really reliably determine where the reflected wave is and what the aortic component of pressure is. Wave intensity actually allows you to accurately look at timings and accurately look at the amount of energy that's reflected. This is Charlotte, who's done a lot of this work. This is actually work that she did in a spare time in between doing her thesis, which was on pacemakers, and in between having 2 children. So in a spare time, she produced a series of papers here. And basically, she showed that this wave reflection was significantly reduced in the amlodipine arm compared to the attendal arm. And actually, if you look at patients in our Ascot sub-study and look at their prognosis, those patients with least wave reflection had a better prognosis than those who had more wave reflection. So I think you're starting to get a picture about why these agents that reduce central pressures might be better. Or do we? So our wave model is a relatively simplistic model and explains the systolic behaviour of the aortic wave very well, but doesn't really explain the whole behaviour. And it's very difficult to get away from the fact that the central large arteries have an important part to play in that arterial pulse. And you just have to do a transesophageal echo and look at the aorta and see it pulsing to know that in systole, the elastic aorta is storing energy that gets released in diastole. And so completely ignoring this might cause problems. So Batman comes in again. And so Kim, in collaboration with John Tyberg in Canada, kind of again sought to solve this problem. They developed a methodology from the arterial pressure to estimate what the effect on the pressure is due to the elastic Vinkessel capacitance effect of the aorta. And Justin Davis, you'll see a lot of pictures of Justin going forward from here. Justin did a lot of work in the aorta, looking at the different components to account for this arterial pressure wave. And essentially, if you put Kim's algorithm in, you can subtract the reservoir aortic pressure from this, and then you can apply wave intensity after that and get what's more like, we think, the true pressure imparted by the heart going forward and the reflected pressure here. And if you compare the wave here, which ignores the Vinkessel, you can see here's the forward pressure from the left ventricular contraction, here's the reflected pressure. If you compare it to here, where the Vinkessel is taken into account, there's a little bit of a reduction in forward pressure, but it's predominantly the reflected pressure that's much, much less. So that gives us a slight problem, because actually these drugs that differentially affect the heart is it really the Vindkessel, the aortic capacitance that they're affecting, or is it wave reflection? And this is really important, because actually when you're designing drugs to treat hypertension, if this is the thing that they're working on, this is where you want to design new drugs to affect. If it's the wave reflection, then clearly you want to focus on this aspect. So the mechanism is really important. So we thought, well, it must be the Vindkessel. Everyone's wrong. So Justin went back and looked at the Cath data and decomposed the Cath data to take into account the Vindkessel and account for which pressure changes were the ones, which of these pressure regions were the ones that accounted for the adverse outcome. And interestingly, it wasn't this. It was this tiny wave reflection after all that's the most important component. So actually it is wave reflection that seems to be most important. But I hope this has given you a kind of illustration of how some of the interaction we've had with our engineering and basic science colleagues have really helped to understand physiology in more detail. Now well, for the last decade really, there's been a lot of hand-wringing about the UK clinical academic medicine decline, and lots of headlines. And we've, I think, acutely felt this in cardiology, largely because the NHS has suddenly become well-funded, or had been. And so a lot of our bright people have been attracted by these fantastic techniques with fantastic role models who open up arteries in patients with a heart attack. Here's a blocked LAD, balloon going down, beautiful open up LAD. Patient feels better, you've improved their prognosis. It makes the doctor feel really good, makes the patient feel better, you've helped them. Our electrophysiologists can cure many arrhythmias now. And so it's no surprising that our bright, energetic people have gone into these clinical specialties. And the modern NHS is becoming a consultant-delivered service, not a consultant-supervised service. So the time for people to do research is small, if not non-existent. So I think in cardiology, a lot of people in the last decade have gone into clinical cardiology, a lot of our best people, and we've felt that. So one of the responses to this decline in academic medicine has been the setting up of the Academic Health Science Centre, and Imperial was the prototype for that. And I think very importantly for us and our unit was Nick's appointment as CPG director, because almost as soon as this happened, the country went broke, Lehman's collapsed, and suddenly the amount of money there's available declined, and we've had to make radical cuts in our service. And having someone at our head who's very academically inclined and orientated has meant the academic program's been largely protected and cherished within all the big cuts we've had in our clinical service. And I think Nick's appointment has been really important to us. I'm just thinking about missing something there, maybe not. Just going sideways again to cardiology training in Northwest London. So subsequent to the AHSC being set up, Richard Sutton decided to take a well-earned retirement and has gone to the sunny climes in Monaco. And when there's a change, sometimes the thing that's been cherished and well run sometimes can go awry. But I'd like to think Darren and I, who are Richard's successors as training program directors, have really held the values that Richard has had, and we've focused very much on people's academic ambitions and supported people within the training program. And so hopefully there hasn't been a big change to the ethos that Richard set up. In parallel, NIHR has set up academic clinical fellow lectureship, ACF and clinical lecturer programs, which I think have been really, really important to us at Imperial. So Nick Peters and Peter Collins have headed this for Imperial, and essentially these posts are clinical posts whereby you have 9 months of clinical training and a protected 3-month period of academic training for over a 3-year period. And the young doctors who go into these posts then have got time to actually do research, to write grants, to get funding for their PhD, and it's really helped to get a lot of people into the academic programs. If you get your PhD, you can apply for a lecturer post, which is 50% clinical and 50% academic. And again, it's a really good transition to get people to becoming and applying for grants to become clinical academics. And I'd like to think that this interaction between the clinical training program and the NHI program has been synergistic, and we've really helped to support these people getting excellent clinical training, making sure their research time is protected, and have supported and encouraged them. So again, I'd highlight that as an important aspect in our neck of the woods that maybe isn't so much there in other parts of the UK. And I would say that this has been externally recognised, the excellence of our training programme, because when extra money has become available to fund more posts, it's been sent to us in cardiology within North West London because of the success of these programmes. So we've got extra posts because of that. Okay, back to the research programme, and we've gone from the arterial system into the coronary arteries, and this was a big step. To actually calculate wave intensity, you need flow and pressure, but you also need wave speed. And in the peripheral system, when you plot pressure against flow in the early part of the loop, this is linear, and so you can derive wave speed from that. In the coronaries, the pressure flow loop is all over the place, and you don't have that relationship. So how do you actually do wave intensity in the coronaries? Well, Batman went to his bat cave again and came out with a method of measuring wave speed at a single point that Justin then validated in the aorta, and we took that into the coronaries. And I have to say, this has been a pretty difficult process, and I'm not sure without all of these people it would have been possible. Kim's brilliance, obviously. Alan, in just understanding the physiology, understanding how to make measurements and when to make them and how to make adjustments. Daryl's mathematics, and Justin's drive and computer programming. All of these things together kind of allowed us to take this into the coronary arteries, and that's provided a huge amount of data for us. Running slightly short of time, so I might just accelerate through the next few slides. But essentially, the reason the coronaries are absolutely fascinating is this is our catheter here in the left main stem. If you measure pressure and flow here, here's the pressure wave. The flow wave has got very little flow in systole, predominantly diastolic flow. If you make your measurements 1 centimetre away in the aorta, you've got exactly the same pressure tracing, but a completely different flow velocity tracing with systolic flow. So, a centimetre makes such a huge difference. Why is there such a difference? Well, this is, again, Justin's work measuring wave intensity in the coronary arteries. And I just want to highlight, you can see left ventricular contraction here. When the LV contracts, though, there's also an immediate wave coming distally, and that's because the contraction, it's not squeezing the small arteries, but it's imparting pressure to the small arteries, so there's a wave coming distally forward as well. And that wave coming in the wrong direction chokes off systolic flow. In diastole, as the heart relaxes, and suction is the wrong word, but I will use the word suction because it's easier to understand. So as the heart relaxes, it creates a suction wave, and this kind of sucks flow forward into the arteries. So it's this kind of suction, this relaxation that the left ventricle does that kind of fills itself with blood and causes the increase in velocity. And if you look at patients with left ventricular hypertrophy, the greater the LV septal thickness, the lower, the smaller this wave is. So there's less suction, less coronary filling. We've looked also in aortic stenosis and matched patients for left ventricular hypertrophy, the same kind of LV masses in hypertensive patients and aortic stenotic patients. And there's a huge difference in physiology, despite the left ventricles being the same. And again, I'll skip over this just in the interest of time. I will talk a little bit about this fantastic model that we have, this clinical research model of TAVI, whereby you can deploy a valve on a stent across the aortic valve and relieve the outflow obstruction in the matter of a few seconds. And this allows for beautiful physiological experiments, because you can measure wave intensity in the coronaries, change the outflow obstruction, and look at those changes almost immediately afterwards. This is much better than animal models. Animal models, you band the aorta, but the banding is distal to the coronary arteries. It doesn't really give you that much of an insight in coronary physiology. So again, Justin's driven this work, and I'll just take you to this slide here. That's wave intensity before and after. But this graph here shows the area under the curve of the suction wave, and at baseline, there's a very, very high suction because there's a huge pressure in the ventricle, and as it relaxes, it imparts a big suction to get a huge amount of blood to supply the ventricle that's needed to work really hard. If you start pacing the heart, this wave declines very quickly, so there's no reserve in this really sick patients. Immediately after TAVI, so seconds later, the suction wave declines because it's not needed, because there's not such a big pressure in the LV, but there's suddenly reserve, so you can pace and the heart can respond to this. And of course, by looking at this instantaneously, you can separate the hemodynamic effects from the effects of left ventricular hypertrophy regression with further time. So it's a beautiful model. In terms of further applications, once you start doing work in areas, you get other ideas. Now, this is an intermediate stenosis, and in modern cardiological practice, we'll usually assess it with a pressure wire to try to assess whether that stenosis is significant or not. And in order to look at the pressure drop across this, you need the microcirculatory resistance to be low and for it to be constant. And the traditional way to do this is to give adenosine. It's a bit of a faff in the Cath lab, but actually, if you target your intervention using this FFR methodology, outcomes tend to be better than just using eyeballing to assess stenosis. So it's an important aspect. So Justin, during his work in wave intensity, recognised that actually if you go to late diastole where there are no reflected waves, actually microvascular resistance here is low anyway and is constant. So why do you have all the faff with adenosine? Why not just make the measurement here at the end of diastole? So Justin designed a series of experiments. This is Shai, our research fellow, who's been doing the work, and this has been done in collaboration with our colleagues in Madrid. And Justin's compared basically FFR, which is adenosine mediated, with just measuring at rest the pressure wire in this late period of diastole. And you can see the resistance is the same with adenosine as it is just making a measurement in that period. And actually, if you plot IFR versus FFR, it's a pretty close correlation. If you plot FFR versus FFR measured in two different occasions, the scatter is much the same. And Justin's got funding and set up a multi-centre study involving many centres in the States and also Europe to look at this new technology. So again, it's developing something from a concept to start with now to work that and technique that hopefully will improve patient care. Just last couple of slides just about the work in our department. Justin's got a big group around him now. One of those is Nicholas. Nicholas is an engineer in our department, and Nicholas and Justin have developed a stent with a stenosis in it. And this is a very valuable piece of engineering because we've got a known stenosis that we could put into animal models, and then we can see how good we are at assessing that stenosis with our techniques, if that makes sense. And so you can do it in stable models, you can do it in infarcted models, and you can see the stability of your measurements in different series. And it seems pretty intuitive to do, but no one's done it before. And for clinical cardiologists, this is a much more intuitive way of doing this than actually banding arteries from the outside. And I think you're much more certain in terms of the degree of stenosis that you've got because you've designed your technique because of that. But the point I want to make is we're taking things forward and expanding our horizons by having engineers embedded in our department now. And Daryl's got 3 engineers working on this project, Keith, Niti, Masood. Graham Curl's a very, very bright registrar who's doing his PhD in this. And it's a typical Daryl thing. Daryl decided that he wanted to design a self-teaching echo. Everybody thought he was mad, and there are lots of ideas that Daryl's had where everyone thinks he's mad. And then a year down the line, it looks like it's working out, and everyone says, yeah, no, I thought it was a really good idea when you started. So basically, the kit here assesses whether we're on axis or not, and whether the heart is straight by the velocities that it picks up in the baseline of the heart at the mitral annulus. So the mitral annulus is actually pretty easy to detect, and so it tells the inexperienced or or not at all experienced person who's doing the test to move your probe one way or the other way. So when it's straight, it then finds the annular aspects of the mitral valve and finds the transmitral area and interrogates these with Doppler, and then automatically traces the tissue Doppler and the transmitral filling. And automatically gives you an index for the ratio of the two, which is a reasonable surrogate for fluid status. So we're hoping this technique, well, we're confident this technique will be able to help assess fluid status by relatively untrained, minimally trained people. So in the A&E department, when the junior doctor sees a patient in the middle of the night, is this patient overfilled, underfilled? We hope this will give a number that will tell you where that patient is. And for serial measurements on the ITU, again, hour by hour, minute by minute even, you can assess whether this patient will be better with more fluids or less fluids. We're just finishing off this design bit. We're just starting off the experiments within the clinical settings now. But again, we genuinely believe that this technology, which has started off in Darryl's brain, we think will make real difference to patients. And sorry, the point I wanted to make was, again, engineers embedded in our department have really made this technique work and developed it. The other area I just want to highlight is the importance of large data sets. Nish Chaturvedi and Alan Hughes have, over the last few years, set up the Sabre study. This is based on work that Nish originally did 15 years or so. So she looked at ethnic variations in cardiac disease in 3 populations in northwest London: Afro-Caribbean, South Asian, white Europeans, 15 years ago. She's now followed up all of these patients. These are many thousands of patients. They've been extensively characterised, looking again at carotid morphology, echocardiography. In fact, Petros in the audience, I think, did the original echo work in this cohort 15 years ago. And so there's a rich data set now of 3 different ethnicities with data going forward. And Alan and Nish are now looking at the offspring of these patients, setting up a trial to look at the next generation. So again, this provides a huge database by which we can interrogate and understand physiology some more. Alan's also collaborated with the MRC 1946 birth cohort. So these are a group of patients who have got birth data on, have been assessed serially for the last 65, 66 years. And many blood pressure data points over that period, and the most recent data set includes echocardiography that Arjun's been driving. So we can look at left ventricular hypertrophy, diastolic function, and what the influence of changes in blood pressure through the patient's life has been on this. And interestingly, change in blood pressure midlife has got added predictive value on top of blood pressure now in predicting hypertrophy. So actually following people and finding changes in value and addressing those early may be very important. But these large data sets, again, are really important in the way our department's evolved. And the other thing I want to make is just the clinical data sets that we have. These are largely been driven by kind of setting up structures in our department. But the important things to recognise are, first of all, you need a department where there's no ownership of patients, where all of your colleagues are happy for everyone to recruit patients and to put patients into studies. And the other thing is, you've got a young Turk coming around trying to reorganise the structure of the clinical departments when they're first appointed. Actually, in many departments, senior people will get concerned about that and see their power base potentially eroded and stop things from happening. And that's absolutely not the case in our department over the years. And my senior colleagues have all been very supportive and actually not only allow things to happen, but actually facilitated things happening. And I think it's important to reflect and the importance of the whole group around being academically orientated and pushing in the right direction. Okay, we've had a big change in the recent past. We've had a merger with the Hammersmith Hospital. Our Cath labs have all moved over to Hammersmith. We're just building our 4th and 5th Cath lab in A block. We've opened up, I think we've got 25 beds now around this 5 Cath lab unit. So it's a fantastic facility for treatment of acute patients with coronary disease and arrhythmias. It's a fantastic facility for treating, doing research in, and our clinical lab is our academic research lab. And what's really important, again, is the culture of the people around. And I couldn't find a photo of all the Cath lab staff, but what's absolutely crucial is when a research study comes on the table, people don't go, oh. But people enthuse, yeah, fine, let's get on with it and do it. And we've absolutely got that culture. And our clinical cardiologists are brought into the program. They do the experiments. They're part of it. And it really is a really vibrant culture we've got here. In addition, this is ICTM that's just opened, as you know, at Hammersmith. So we've got other teams that have recently come in from other campuses, from South Kent and the Brompton, and we're looking forward to making lots of friends and lots of collaborations across there, and hopefully getting a lot of facilitation and synergy between our clinical departments and our basic scientists. This is just a picture of Justin and Daryl. This is doing first-in-man work and renal denervation and heart failure. We strongly suspect that this will be a very important treatment, and again, this is somewhere where Imperial's right at the cutting edge. So, back to the training programme. So since we were appointed by the Deanery to lead training, the Deanery stopped providing training, and it invited tenders for hospitals to lead training. So I wrote the Imperial bid, which won the training programme for North West London. Unfortunately, they made me apply for the job again, so they hadn't opened it. So I applied for the job again and got the job. So I have 3 interviews now, effectively, for the post. So I'm training programme director, and Daryl is the academic lead. And I don't think there's been a real change in what you can do with this post, but I think it's given us confidence going through this tendering process to really be more dynamic about driving the training programme. And so this is us. We want to have and we are starting a system where there's no tolerance of poor training. If hospitals don't train people well, we'll withdraw the posts, and we've done that already for a couple of units. I have to say the response of those units has been excellent, and the training in those seems to be much better now, and we'll assess that when the SBRs come for their ARCPs in the next few weeks. We've got now engaged really enthusiastic trainers, representatives from the different hospitals in North West London. We all get together once every 3 months and look how we can improve the training programme and discuss the trainees and how we can support them. We've set up an academic focus from the start. So any new clinical trainees, Daryl's set up an academic training programme for lectures for them to get them in the swing of academic techniques. And in the past, people have had clinical mentors and clinical supervisors over the years. But we've found that by the time they think about research, it's almost too late. So we've now set up for all new trainees coming in to have an academic mentor as well, to direct them towards supervisors who might be good for them, and just advise them about starting early to think about their research programme. And we've tried to, and I think successfully, brand North West London as the focus. If you want to be an academic cardiologist, come to North West London. We'll support you and develop you. And I think this is really starting to pay off. So just kind of reflecting on my first part of my career, I hope. I think it's really difficult for young consultants to do research in busy NHS jobs. The NHS basically takes your time, quite rightly. And the first year is really important. You've got to be doing something academically to start generating more ideas. So we've got to really cherish our new appointments and support them in doing research. And I think we have to somehow get protected research time in people's programs. Those who demonstrate they can do research need to have ring-fenced time. We need to get funding to support that. The environment's all important, and so my senior colleagues, Peter Sever and Rodney Fole, Wynne Davis, Nick Peters, they provided really supportive environments, and it's fun to work. There's not one day in my 20 years in kind of North of London I've not felt depressed coming in. I've always been enthusiastic about it, and it's because of the environment that my senior colleagues have set. Life's all about people. Varied skills are crucial, and it's important to get people who are better than you and then support them. and there are lots of people better than me that have been brought through the unit since I've been there. And the best way to get synergy, I think, is really to influence both all of clinical, academic and training themes, and I think that's really important to think about going forward. In terms of messages, it's a tragedy that 12 years ago we didn't get our big West London centre. I think all of us, clinicians and academics, need to be pushing for this merger as soon as possible. We need to be competing with the Mayo Cleveland Clinic. We keep talking about these things, we never do them. All the rest of the country are getting organised into big centres, and we're lagging behind. We're in high volumes of patients. There are academic clinical synergies between our clinical departments, and we need to bring them together. And at the moment, it's all about competition. Most of our income comes from patients. We're fighting each other for these patients. It creates a really bad time. We have to get merger. We're working towards getting routine enrolment of patients coming through to our Cath labs and other clinical environments to be consented for research. This is a really important piece of work that we're doing over these next 12 months going forward. The other thing I think we should think about is, at the moment, certainly in our units, we've got research fellows, engineers in our department. I think we need to think about the next step forward. We should be having senior investigators, so clinicians, cardiologists, based in engineering departments. So day to day, you bump into people in the corridor, you have these conversations, and vice versa, engineers based in our clinical departments. And I think that's something as Imperial we ought to be thinking about how to make these things happen. This is the real important future, which is all of our ACFs, some of our research fellows, our clinical lecturers. Some of the first wave, Justin, Zach, Alex, are already on the staff. I hope Obi and Charlotte will be close behind them. But these people are really important. People like Ramsey, who's doing work in Doran's unit and bringing together the clinical department with Doran's department. Sunta's working with Michael Schneider. There are lots of people here that work at the interfaces, and we're getting some really, really bright people. I think Judy, as our most recent ACF appointment, she got first in everything at Oxbridge. She's published extensively as an SHO. She's a really nice person. She's a really good doctor. These are the kind of people we're attracting now into our ACF program. Claire here, we recruited as a medical student. She's published many first author papers as a medical student. She's now doing a PhD in at the Brompton and the MR unit. Richard, again, another of our medical students, we kind of headhunted and sucked into the department. He's just about to start as an ACF. So these people I really expect to deliver, and I hope many of them will become chairs, hopefully at Imperial, but certainly somewhere in cardiology going forward. And finally, I mean, there are thousands of people that have really helped to support the department and make our unit what it is today. Simon and Jim, I owe a great deal to. They trained me both academically, well, say academically inverted commas, and clinically when I was young, and helped to kind of set my mindset. These are the real academics here. These are true translational clinicians who really bring ideas from concept to helping patients at the end, and these are the kind of real stars of our department. It's really important not to underestimate leadership. I think the way our department evolved has been largely set by the leaders that we have that set nice open departments. There's no what's in it for me issue, just a supportive, fun environment. And Rodney I've kind of had most to do with over the last 20 years, and Rodney appointed me and has supported me every day. And I think Rodney's personality is kind of stamped on the unit, and it really is a dynamic, fun unit, a great place to be. And I think the future's great. We've got fantastic young people coming through. We've got this fantastic facility, clinical facility on the Hammersmith campus. We've got new groups of people and friends coming to join us that we can integrate with and develop kind of synergistic programs. And I think, I'd like to think that, we're what the Academic Health Science Centre should be about, and cardiology is thriving. So I'm sorry I've gone a bit over time, but thank you for staying for the period.